You want to feel like yourself again. You are not too happy about the signs of aging, like you're dealing with skin that's changing, muscles. You've maybe lost your energy, your interest in sex. You just want to feel like yourself again, maybe even better. But you're also very confused because there's so much misinformation and conflicting information out there about hormone replacement, hormone supplementation. And the last thing you want to do is put yourself at risk of getting breast cancer or Alzheimer's or any other complication that could lessen your quality of life. You just want answers. I get it. And today I have an amazing guest for you who's going to answer all of your questions specifically about testosterone. My guest today is Dr. Kelly Casperson. She is a board-certified urologist. She is a surgeon. Her name has become synonymous with testosterone. She's the author of the best-selling book, You Are Not Broken. She's down to earth. She's funny. She is like getting it shot straight to you from your BFF with spiky hair. And we are so lucky to have her. This is the first time we've ever had a guest on the Chalene Show 5 times. Kelly Casperson.
Hi.
So excited to have you.
Thanks for having me.
Well, it's about time because we need answers. It's kind of a little bit sad that so many of us women, we're learning what it is we need to know and how to empower ourselves to talk to our doctors from people like yourself. Women, specifically, women in this industry who are like, okay, ladies, listen up. Here's what you need to tell your doctor. Yeah. So the first thing I want to ask you is, why is it, if we're talking about testosterone, my own audience, when I polled them, so many women don't even think of testosterone as something women are supposed to take. Why do we think of it as a male hormone?
Yeah, it's such a good question. So even Google gets this wrong. When you Google testosterone, it will say this is the male hormone. And what the experts did in the 60s and before that, when they were figuring out hormones, they said testosterone's for the men and estrogen's for the women. And we really gendered these hormones.
That makes sense.
And so now we don't believe that men need estrogen, and they do, especially for their libido and their bones, and women need testosterone. And the other thing we don't know that will blow your mind is that in your body, in your 20s and your 30s, you have more testosterone than estrogen.
As a woman.
As a woman. You actually make testosterone, and it gets converted, some of it, to estrogen. And nobody knows that your estrogen is literally coming from testosterone. It can't be made any other way.
So is that one of the reasons why we are regularly hearing about men, like low T, men, we're always talking about men supplementing with testosterone. We have testosterone. And so obviously if we want optimal health, what are some of the ramifications? What are some of the consequences if we just are like, oh, well, it's declining. My doctor says I don't need to worry about it. How does that affect our health?
Yeah. I think what a lot of people don't know about midlife is why the changes are happening. Mm-hmm. Everybody just thinks it's a hot flash and your period stop and that's midlife. But those things are happening because our hormones are going down. And for testosterone, it actually goes down and can go down before your periods stop. The period stopping is kind of an artificial time of like separating premenopause and postmenopause.
Yeah.
But you can have low hormones and issues with low hormones, certainly when you're still having periods. And that's a big myth that a lot of people think, oh, you're fine until your periods stop.
So let me ask you this question. If we'll talk about some of the symptoms. If I am a woman who's like 35 years old and I'm having some of these symptoms, I'm nowhere near menopause. I think I'm nowhere near menopause. Would it be wise to test my hormones and possibly supplement if I'm low?
Yes. I think your big challenge is going to be going to a doctor who understands that hormones can change and go down before your periods stop. Because doctors didn't get taught about hormones for about 20 years because of the Women's Health Initiative that put this big scare into the entire medical community, ripped hormones out of a lot of women's hands. And now 20 years after that, we're just starting to be like, oh, these things are safe. Women thrive on them. They do well. And for testosterone, it's the acceptable reason is low libido. And when you think acceptable, meaning like what the medical community knows testosterone's useful for.
Okay.
But when you think about it, why is your libido the only thing that you should care about?
Yeah.
Right.
Yeah.
And libido is a mood, which means testosterone works in the brain, right? So we have data that testosterone helps clarity, brain fog, recall, kind of this, brain fog that people complain about in midlife.
Yeah.
Hormones can sometimes be the answer to that.
So I asked my audience, I told them you were coming. I've had you on the show many times. I'll link to those previous episodes in our show notes because we've talked about sexual health. We've talked about painful sex. We've talked about a lot of topics, especially because of your background. But I asked them specifically for this opportunity, like ask away and I will get your answers from the expert. The first question is, how do I know even that I should be advocating for myself? How do I know that my testosterone might be low?
So signs of low testosterone are actually pretty vague, right? Because it works all over the body. It might be fatigue, trouble recovering from workouts is a big one that I see. Or I'm working out and I'm just not getting muscles, right? I'm just having trouble gaining in the gym.
Yep.
Fatigue afterwards, tired. And then that kind of vague brain fog, right? It's like, I'm just not as sharp. I had a woman come back after being on T and she's like, I can math better. I had one lady come back and she's like, my German is back in my brain from learning it from years ago.
Dang.
So it's really a disservice to say that testosterone's only for low libido. But again, in the medical community, that's currently the only accepted reason to be on testosterone. So you really do have to advocate for yourself.
The things you just mentioned are things that also I hear, like those signs are things that people associate. Myself, I remember hearing like adrenal fatigue or like burnout.
Yeah.
So are some of those symptoms very similar to like what we're hearing for adrenal fatigue? And is adrenal fatigue a thing?
So in the medical community, adrenal fatigue's not a thing. What we think in the medical community is these women, they're going through hormonal changes. Nobody's looking for it. Nobody's helping these women in perimenopause.
Yeah.
Right? They're still having periods, but they just don't feel like themselves. And so they're going out to maybe other alternative practitioners, which can be a wonderful thing. But then they're being told they have adrenal fatigue. And we're like, adrenals don't just kind of putz out, right? The adrenals certainly keep going more than your ovaries do.
Sure.
So it's like this common thing of perimenopause and menopause that nobody's looking for. And so they're getting these other diagnoses like fibromyalgia, chronic pain, maybe their migraines are coming back. And a lot of it, the unifying reason is the change in hormone.
Okay. So is there an age range where it's like you should probably start advocating for yourself, and if you're experiencing any of these symptoms, it's not too early?
Right. So average age of menopause in most modern countries is 51. So America, average age 51. So that's average, meaning 50% of people are going to go through menopause before that.
Yeah.
50% after.
Right.
And then perimenopause is a very vague term, just meaning the years around menopause. That can be early 40s. We see it in late 30s because it's going to be different for everybody.
Yeah.
The problem with perimenopause is it's a clinical diagnosis, meaning there's no blood test to say I'm in perimenopause.
Oh, is that what clinical diagnosis means? Oh,
Clinical
okay.
diagnosis means you say what's bothering you, and the doctor says, well, let's rule out diabetes. Let's rule out, trouble with your thyroid. So you can go in and get all these tests, and the doctor says, your tests are fine. It's like, okay, well, it's probably perimenopause.
Okay, so you really have to go based on your symptoms, how you're feeling, and then you have to be an advocate and say, like, I want to have my. How do I specifically ask for a hormone panel to be done?
Yeah. So the testing of hormones is interesting, right? Because there's no blood test that says you're in perimenopause. And the other thing about your hormones, especially in perimenopause, is it's a roller coaster. So I can check your blood work today, but that doesn't mean that's going to be what your blood work is next week, right? So people want to say, I want to get my labs tested. But don't hang your hat on that lab because it's going to be changing. Because as your ovaries are kind of going offline, it's like a reverse puberty, right? So we're kind of going up and down and up and down. Sometimes super high up, super high down. And so blood work is useful. I like to get it as a baseline.
Okay.
Right? But don't hang your hat on saying I always have a high estrogen or I always have a, because it will change in perimenopause by definition.
You said something yesterday when we were at dinner that I was like, that is such a smart thing to tell women, young women, like women who are like 20, 25. Get it tested so you know your baseline, so you know what you should be at for optimal to feel optimal when you're in your 40s, when you're in 50s. Would that even be possible? I mean, you'd have to pay for it out of pocket, right?
I mean, probably, or you can ask for it, and there's ways doctors can get labs paid for, But yeah, we were talking about, well, how do you know what your testosterone should be or what your estrogen should be? And we're like, it'd be nice to know what you were at 30.
Yeah.
right? But then you got to take the time machine.
So the baseline, I think that's an important part of this conversation because so many of the questions are, what should my numbers be? How do I know if I'm too high? How do I know if I'm too low? My doctor says this is within a normal range, but I still don't feel good.
Yeah.
So talk to me about baseline and why this is so individual.
I think women want the lab to tell them if they're good enough or if they're on target. They're always looking for that external validation. It comes down to how you feel. How do you feel, right? Not like, let's try to optimize you to a certain level. Certainly, the higher you go, the more side effects you're going to get, right?
Good and bad?
Good and bad.
Okay.
My friend Rachel Rubin says when you play with hormones, you get side effects. But it really depends upon how you're doing and not just a lab test. But to what you're saying is even the lab test, especially for testosterone, because we have not been giving women testosterone, it's hard to know what optimal is going to be for you. And I see so many women, they say, I was told it was normal. And I look at it and I'm like, no, you're having symptoms, you're tired, you have a low libido. And when I look at your lab test, I'm like, no, that's probably not where you were feeling good when you were 32. We just don't have that comparison.
Is it that the general practitioner, so, you shared some statistics with me that 0.1% of physicians in the United States their primary focus is hormonal women's care or are certified to treat menopausal women or even perimenopausal women. So is it that our general practitioners, when they say, oh, no, you're within normal range, meaning you're within normal range because normally women just decline and don't do anything about it. So this is normal. This is a normal decline.
Right. Oh, I mean, I would say, because I didn't learn this in medical school, most doctors don't even know testosterone's in female bodies. Right. And so many comments from my women, they're like, they told me I'm going to turn into a man. They told me I don't need it. And so the general population just hasn't been trained in female health. Wow. We're just starting.
What a gap. It's criminal.
It's crazy. Like the fact that like testosterone is important for bone health, brain health, cardiac health, of like, we're just saying it's okay for low libido right now, but we have all this other data to say, yeah, but there's more to this hormone than just your sex life.
What are the, one of the greatest fears and probably some of the most common questions are about breast cancer. And I've got comments from women who have gone to their doctors, and because they have a family history of breast cancer, they've been told that they are not a candidate for any hormone replacement, but specifically testosterone, estrogen. What do we need to know about updated studies? Is a woman at risk of breast cancer if she starts testosterone supplementation? So
testosterone is very interesting because before we had current treatments for breast cancer, testosterone was actually used to treat breast cancer.
Really? Yeah.
Back in the day. So we think testosterone has a protective effect on the breast. And they're looking at safety studies, right, which need to be done. So there's just this new study that came out looking at an over 10-year period, women on testosterone compared to women who didn't take testosterone. This is postmenopausal women.
Okay.
The women who were on testosterone in this study had a 50% decreased risk of getting breast cancer. And I'm like, if there was a drug that decreased your risk of breast cancer by 8%, everybody would be on it.
Absolutely.
Why aren't we studying this more?
Yeah. So now, and I know there's some older studies, which we heard are flawed, that keep getting kind of regurgitated and repeated by physicians that scare a lot of women away, and specifically the Women's Health Initiative, right? And in looking at that research, share with us why. We're going to read a headline from an outdated piece of research. And, the average person isn't like picking apart a study. Yeah. They're not going to PubMed. They're not like going like, where are the flaws in the study? They're just reading a headline and they're like, this is a study, so therefore I have to avoid testosterone, or I have to avoid hormone replacement because this study says it will increase a woman's risk of dementia. It will increase a woman's risk of breast cancer. Mm-hmm. So what do we need to know about some of those studies that have been walked back?
Yeah. So the Women's Health Initiative was a multi-billion-dollar study, and it broke through the media in 2002. And it said, stop your hormones, you're going to get breast cancer, don't do it. And so we just put a big halt on everything. About 70% of women in this country were taken off their hormones because of the Women's Health Initiative, which is interesting because now that we're 20 years on, we don't even have as many women on hormones as we did in the 1990s. Women were taking
Wow.
hormones, and we took them off the hormones
Wow.
for fear. What we know now is that, first of all, the medications in the Women's Health Initiative are not current standards for hormone replacement. We use a bioidentical that is exactly like what your body makes and is considered to be very safe.
Which was not what was used in the study.
Which was not what was
Okay.
used in the study. That was the standard at the time, but it's not what's used now.
Yes.
What we know now is what that study did is it said the women who were on the estrogen progesterone arm, synthetic, had a higher risk of breast cancer than the placebo group.
Okay.
The placebo group was previously on estrogen, and we know that estrogen decreases your risk of breast cancer. When you clean that up, there was no increased risk of breast cancer in the treatment arm. That's where all of this came from.
And the age range of the women that were in the study.
The average age of the women in the study was 63, going all the way up to almost 80. So these women were older, they were less healthy. And what we know now is the sooner you can start hormones, the healthier you are, the less damage that's been done because of aging. Because we all age, hormones don't prevent us from aging. But if we start on them early, we're not going to get those increased side effects, especially with the formulations we use now, which are transdermal, which is much safer than the old oral formulation.
Okay, let's talk about which method, because a lot of questions. Which should I use? Pellets seem like they're becoming more expensive. Quite a few questions about the which is easier to control side effects, to titrate up or titrate down. So share with us, what are the options and what do you think is the best, if there is one?
Yeah, I mean, I see like this best all the time because, again, women want the best. Right?
Yeah.
But it's so individualized. What works for one person might not work for the other one.
Yeah.
Pellets came around because women were suffering and the traditional medical system said you can't have hormones because it causes breast cancer. So women were kind of pushed out and they said, well, let's do these pellets because they're bioidentical, they're safer, and women were suffering.
Why were they considered safer?
Because they weren't the hormones used in the Women's Health Initiative. They are bioidentical. Right. So pellets, they are exactly what our bodies make. But pellets aren't covered by insurance. So like you said, they're expensive. And they also tend to make you have higher values. So you're going to get more side effects. And I would say if you're at sea level and you get flown to Everest Base Camp, it feels very bad. It's like, if you're at sea level, I want to take you to Denver. Denver feels good.
Yeah.
Right? But if you go from 0 to really high, you're going to say, that's where you get these stories of like, my hair fell out. I felt wonderful until I felt horrible. It's like, we just want to get you to where you're feeling good. We don't need to go higher. And with pellets, you can't dose that like you can dose a patch or a gel or a cream.
Yeah, that makes sense. That makes so much sense. Okay. This gal says, almost 10 years of menopause. Am I still a candidate? Is it too late?
Yeah. So it's a good question. So one type we didn't even talk about was vaginal, or local pelvic. Anybody can be on that at any time.
Really?
Yeah. So I have, 85-year-olds with recurrent UTIs. You can start your elderly mom on vaginal estrogen to decrease her urinary tract infections.
Totally. Why is that different than some other form?
Because of dosing. So pelvic estrogen it's like putting on sunscreen. Like it's just local. It's not going in your bloodstream. It's not going anywhere. It's just taking care of bladder, vagina.
Okay, this doesn't make sense to me. Because if you're putting it on your skin, whether it's vaginally or on your wrist, why does it go into my bloodstream if it's on my wrist, but not if it's on my vaginal area?
Dosing. So a much higher concentration when we give you a systemic here. It's much lower concentration when we put it in the vagina.
Okay.
Now, there is one vaginal ring that is a high enough dose to be systemic. So it gets a little nichey. That's called the fem ring.
Okay.
But then
never heard of that.
Then there's it's cool because it's plug and play, right?
Yeah.
You put it in and it's great. Tends to be expensive, not always covered by insurance, but you don't have to do a daily application. That's why there's not one best, right?
Yeah.
It's like some people love the plug and play.
Yeah.
Some people don't want a ring in their vagina.
Right. And then there's that person who has ADHD and is going to forget to take it or forget when she's, put some on her skin. And so then the ring is like, that's a solution for her. It's about lifestyle too, right?
Totally. And the ring will cover your vaginal needs and your systemic needs for the reason for being on the fem ring. Versus if you just take a systemic like patch, it might not be a high enough dose. You might still have vaginal dryness, overactive bladder. Then you can put a pelvic formulation down.
So even a woman who is a breast cancer survivor herself, perfectly safe to do the ring.
The local ring, so
Local ring.
Estrogen,
Mhm.
not the systemic ring, which is
Okay.
ring. Those are the two different brand names.
Okay.
And again, comes down to dosing.
Yeah.
So there's a statement online by the American College of Obstetrics and Gynecology that says local vaginal estrogen is safe for breast cancer survivors. Now, if you're actively being treated for breast cancer, so you're receiving medications for it, and
Yes.
it's an aromatase inhibitor,
Yes.
we get the permission from your oncologist.
Mm.
And we say, is she thriving? Is she suffering? Can we start this? Is it safe? So that's the only caveat. Otherwise, we say, yeah, your breast cancer was 8 years ago and you're suffering from painful sex, urinary tract infections, getting up at night to pee, completely safe to be on a vaginal estrogen.
I want to stay on price for a second. Why is it more often than not, testosterone is not covered for women?
Because it's not FDA approved for women.
But it is for men. And we both have it.
Men, yes. Men have over 20 different brands of testosterone that they can take, and women have 0.
Why? Am I insane? Does this make any sense?
No, it makes no sense because testosterone is in every body.
Is it because we haven't done the research?
We've done some research. We're actually we're coming out with a testosterone patch for women. We have great data, and it was for low libido. Great data to show that it increases libido, all domains of sexual function, arousal, orgasm, lubrication, desire, helps all of it. Also helps hot flashes.
Wow.
But this testosterone patch was coming out right after the Women's Health Initiative.
Oh.
And the big fear about risk, right? So the FDA said, halt everything. We need more data on risk before we can get an FDA-approved product. And it's coming. I know a company that's going to work to get it done, but it's going to be approved for low libido. So Australia already has this. Australia has an approved product. It's for low libido. And my Australian women, they say, I have to go in and tell my doctor I have low libido to get my testosterone.
That's crazy to me.
Right. Why is that the only thing that testosterone does in our body? It really makes no sense.
It's all about sex. I know that everyone's different, but is there kind of a range that you find in your practice most women feel pretty good at these levels?
Yeah. So I'm using numbers that are American numbers. So if you're in Europe or if you're somewhere else, it depends upon how your testosterone's measured. Right?
Okay.
And so in America, a range in the low double digits. So certainly a woman between 50 and 80 is a range that you tend to feel really, really good and you don't have any crazy side effects.
50 to 80.
Yeah.
Okay.
And once you start pushing into the 100s, the low 100s, certainly when you get to 200, we kind of think the male dose, is 300 and up.
Mm.
So you think about women's dosing at about 1/10 the male dose.
Mm.
So you say, hey, a guy loves his testosterone at around 700. Divide that by 10, a woman's happy around 70.
Wow.
It's just a very easy way to think about it.
Yeah.
Like, where are the guys happy? What's 1/10 of that?
Yeah.
That's where women are. And a big myth is like, will this turn me into a man? Will these things, if we give you doses to be at
that
a
high
level, and we have tons of safety data on that because some women transition and want to live like a man.
Yeah.
They've been on testosterone for years at 10 times the dose.
Yeah.
They do great, right? So you just have to dose to keep it in the female range and you do wonderful.
In your practice, when you're starting a woman on testosterone, therefore, do you start low and increase, or?
There's a standard dose, and it's about 5 for a let's talk about a cream or a gel.
Okay.
It's about 5 milligrams a day.
Okay.
So we usually start people at a standard dose. I always check to see where you are at baseline because I want to know you're absorbing it, that I'm moving the needle, but I really care about how you feel.
Yeah.
Right. So most women come back at around 70, 60 to 80.
Uh-huh.
Most of them aren't having side effects. The most common side effect is just a little more hair growth. They might not like that on the face, but they say, well, testosterone, that's what testosterone does. It's actually very good for hair growth. But you're not going to see the crazy, hair loss, certainly, clitoral enlargement, voice deepening. That's when you're getting into the low 200s, 300s.
Okay.
You can get with pellets, right? Pellets will really shoot women up high. I'm like, I don't want you to have any side effects.
Yeah.
I just want you to feel good.
What about acne?
Very rare. They'll say a little more oilier skin, a little more facial hair growth. The medical term for that's hirsutism. But you're not seeing too much. Most of my ladies will be like, I get a little zit a little easier, but it's not like a.
And is that automatically from testosterone, or could that be from a different hormone?
Could be. I tend to see it more from testosterone.
Yeah. Okay. When you're talking about, these dosages and, women trying to figure out like what's a dosage for them and how they feel their best, I can only speak from my personal experience. I It wasn't like, oh, first week I feel anything different. You know what I mean? Like I just kind of noticed like, oh, you know what? This month I noticed I did get stronger. This month I noticed I did feel more sexual desire. I did notice like I have better energy. I'm a little bit more clear. But I mean, it wasn't dramatic.
No, it tends to not be dramatic, and it takes a while, right? Because especially if you have no hormones, your estrogen and testosterone receptors have to kind of come back online to be like, oh, you've got hormones, you want me to use them, right? So it takes a while for that to happen. In the low desire studies, 12 to 16 weeks for women to say, oh, there it is.
Oh,
right?
wow. 12 to 16 weeks.
And so the
Interesting.
guidelines really say 4 to 6 months. And if you're not seeing an improvement then, even if your levels are up to a range we like, we're like, your low desire is not from testosterone then.
Here's another like personal question that I just don't understand it. Because I've done injection, right? I've done injectable of the hormone testosterone, and I've done the cream. Okay. So if I do an injection, and I'm doing that at the time, I think she had me doing it like once every 2 weeks. Does that make my testosterone like really high for a couple of days and then I'm just like petering down?
Yeah, you get more of a peak trough, especially at 2 weeks. A lot of, men's testosterone, they like the weekly dose on the injections better than the every 2. Because
I see. Yeah. Oh, okay.
And you can feel it, right? Like, oh, right before my injections again, I feel kind of tired. That's the nice about daily dosing is you get more of a steady state.
Good to know. That makes a lot of sense. So that person who is doing a daily dose and forgets, they might actually feel it. But there's no real harm in that. It's just more inconsistent dosing.
Yeah.
Okay. Additional questions. What are the causes of high testosterone when I'm not doing any hormone replacement therapies? But this gal, a couple of people said they had been tested. Every time they test, they're like off the charts with their testosterone.
Yeah. It'd be, again, hard to know if I wasn't looking at it.
Yeah.
Because I think a lot of very normal testosterone levels for women are read as high just because of the lab values.
Yeah.
So to me, I'm like, is it that, or do they actually have like an endocrine condition, polycystic ovarian syndrome, things where they're actually making more testosterone and having side effects from it?
Okay. Is there a length of time that women should consider taking or supplementing with hormones? Should we be, remember hearing from one of my doctors, it's like the minimum dose or the minimum amount of time. Yeah. But it seems to me that that's changing.
Yeah. So again, that came from the Women's Health Initiative scare. Women were suffering. So doctors said, okay, we'll give you some, but just a little bit and just for like a couple of years.
Okay.
So that's really where it came from. And then all of a sudden it was this dogma of like, you had to stop at 65, which is not written anywhere. And the current 2022 North American Menopause Society guidelines say as long as the benefits outweigh the risks, you can continue your hormones. And then women say, what are the risks?
Yes.
It's like, that's up to you and your doctor, right? Are you thriving? Are you doing well? Have you had a major health challenge where you shouldn't be on hormones now, which would be like a heart attack or a pulmonary embolism, like something big. For most women, the benefits of hormones outweigh the risk. And a new study just came out looking specifically at women who are 65 and continued their hormones. Longer life expectancy, decreased risk of osteoporosis, heart attack. We're getting very good, interesting dementia data.
Yeah.
That if you start your hormones young, it's brain protective. The Women's Health Initiative, again, threw women on hormones who hadn't been on it in a long time.
Yeah.
If you don't have a healthy brain to begin with or heart to begin with, that's where you start seeing the increased risks.
And if I recall, when I looked at that study, the statistical differences between the two control groups, the ones that they said there was a moderate degree of cognitive decline, that it was so insignificant.
Very insignificant.
And also these women were 65 plus. So we're looking at like, I don't know, that's an interesting question for me that I received from my mom. She's 75 and she's like, can I go on hormone replacement? So what should she consider? Can she? Is she still a candidate?
So for the vaginal estrogen, absolutely a candidate. She can get on that right now.
Okay.
As far as systemic, so means all bodies. It's going to get in your bloodstream, go to your bones, protect your heart. We have studies looking at older women. Older in this world means 10 years post-menopause. That's kind of why, who's older, right? 10 years post-menopause.
Okay.
So if you're healthy to begin with. They might check her cholesterol, make sure her blood pressure is controlled, make sure she doesn't have any significant heart disease. And certainly the older women, when they get on it, start low and go transdermal.
Okay.
That is the safest route for them.
Okay.
But
It's got to help with muscle development, right?
Yeah. I have women who come to see me and I ask them, like, why do you want to be on this, right? And they tell me why they want to be on it. I want to protect my bones. I saw my mom break a hip and be in a wheelchair. They've got reasons. Let's start low. Let's see how you do.
Yeah.
Started one woman, she was 75, started her on it. She came back and she's like, the veil's been lifted. I can't believe I've been living like this for 20 years. Another lady, I started another lady, a 73-year-old on hormones. Her chronic pain went away. The role of hormones in the musculoskeletal system, like frozen shoulder, hip pain, knee pain, like people's pain gets better because we have hormone receptors in our joints.
Speaking of cholesterol, you said, what is their cholesterol level? And maybe this is more of a discussion about estrogen, but as our estrogen decreases, aren't we seeing a correlation between that and women's cholesterol levels increasing?
Yeah. So estrogen is an amazing anti-inflammatory. It's anti-inflammatory for the brain. It's anti-inflammatory for the heart. So when women stay on estrogen, they tend to have the benefits of a healthier body. You come off of estrogen or you don't start on estrogen after menopause, blood pressure can increase, insulin resistance can increase, and then the inflammatory markers that can, be triggers for heart disease tend to go up.
God. What about, this person says, can DHEA help me to make testosterone?
It's a great question. We don't have great data. So DHEA is basically a pro-hormone. And in America...
What does that mean, a pro-hormone?
Means it'll make testosterone and it'll make estrogen.
Oh,
it can, go either way.
Oh,
right?
Interesting.
And so what's it going to do in you is we don't know, right? And then it's a supplement in this country.
Yes.
So my other worry for it is it a reputable company you're actually taking DHEA?
Yeah.
Supplements are unregulated.
Right.
Right. Probably more data in the premenopausal woman. So her ovaries are working. You can convert that DHEA a little bit better than somebody who's postmenopause and taking DHEA. So to me, I'm like, there's probably more data to take it premenopause than postmenopause, but we don't have any strong guidelines to say who's going to benefit and at what dose.
Is there any risk for the woman who's just doing estrogen and maybe her care provider is just not up to date on testosterone supplementation? Is there any risk of just doing estrogen or just doing progesterone and not doing testosterone?
I would say that's the standard of care right now.
Is what?
Is just to be on the estrogen progesterone.
Okay.
Right? Because again, we gendered these hormones. Estrogen's for women, testosterone's for men. And so we're really starting to have this conversation of like, no, they're all for everybody. Right? And so I think we're just at the very beginning of women learning about testosterone, advocating for themselves, saying, I want this for something other than low libido.
Right.
Right? And validating that testosterone's everywhere in your body.
Yeah.
It's interesting when a woman comes back on testosterone and I say, well, what does your partner think?
Oh.
To hear their story.
Yeah.
And this woman's like, he's noticed that I'm more curious about the world. I'm asking questions again. It's like the stories that come back from women on testosterone are just like so exciting and mind-blowing.
Yeah, it's like when your hormones are in decline, you just feel dimmer, and so like the word that comes to mind for me is vibrance. Like all areas of your life become more vibrant. I know a lot of my questions were women who said, I've started hormone or I've started testosterone and I don't feel a difference. And it hasn't improved my libido. A lot of them were saying that they started on it for libido and they're like, it's not improved my libido. I'm sure you hear this often.
Yeah.
What's going on there?
So libido is complex, right?
Yeah.
How stressed are you? How great is your relationship? Are you sleeping, right? Everything.
Is your spouse attractive? Exactly. Do you find them attractive? Are they being nice to you?
Exactly. And are you having sex worth desiring?
Yeah.
So many people are having like mushy broccoli sex and then they're taking testosterone and they're like, I still don't like it.
Yeah.
It's still mushy broccoli.
Yes. Right? I've never heard of mushy broccoli sex. That's so good.
So libido is complex. Testosterone's a part of it. Some women will start on estrogen and their libido comes back. So really like blaming testosterone or giving testosterone all the credit for libido is oversimplifying this like amazingly complex stuff.
Yeah. Yeah. Could testosterone be one of the reasons why women are having painful sex?
Yeah, estrogen and testosterone.
Okay.
So our vulva, our vagina, our clitoris, very androgen and estrogen sensitive because we have testosterone in our bodies.
Okay.
Right. So some women will benefit from vaginal estrogen. There is no testosterone local vaginal product.
There is no testosterone local vaginal product. There isn't. Okay.
So you would need to compound it. But this is where DHEA comes in.
Go back for a second. What do you mean by compound it?
Good question. So compounded means it's a product made at a compounding pharmacy. It's not a standardized prescription that you can get at Walgreens, Walmart, Target. It's not like a standardized product. It's made specially for you. Maybe you need a different dose. Maybe you have an allergy to something that's in the traditional product, or maybe you just need some testosterone with your estrogen for your vagina.
And I still need a doctor to prescribe that to the compounding pharmacy. Yes. It's not something I can like find a compounding pharmacy and walk in.
Correct.
Okay.
Yeah. And a lot of women will say, oh, I'm getting my hormones that are compounded because they're led to believe that compounding means better. Compounding doesn't mean better. It's just more of a specialty kind of niche situation. And a lot of hormones have great FDA approved, especially estrogen and progesterone, that your insurance covers.
Yeah.
I would say you don't need compounding if it's available and you tolerate those products. Saves you tons of money. But DHEA in the vagina. So the data on oral DHEA and hormones, it's not great. We haven't studied it very well. It's a supplement. We don't really know what to advise women, but DHEA in the vagina for local health, DHEA makes a beautiful vulva and a beautiful vagina.
In the form of a cream.
The prescription for it is a little suppository.
Oh.
It's very like lubricious, which is a word for like creamy and oily. And you put it in the vagina and it kind of melts and it helps the vulva in the vagina and it converts to testosterone and estrogen.
Wow.
So I use it a lot for if a woman, she's on vaginal estrogen and she's not getting the tissue improvement. She's still, especially at that 6 o'clock, it tears, it hurts, it's thinned on penetration. DHEA can bring in both androgens and estrogens, and it's a miracle worker for the skin down there. Downsides of this medication is it's daily.
Okay.
And it's expensive. So
what's expensive? Is it out of pocket because it's not covered by insurance?
Some insurances cover it.
Okay.
But Medicare has labeled it as the sexual health product instead of like a
health.
Right. And so it's not as covered as well because of the bias towards sexual.
Yeah.
Right. So in a lot of insurances don't cover sexual health, whether it's Viagra or other things. So it can expensive, $70 a month.
Okay.
Yeah.
Okay.
But it's for women. I'm like, just try it for 2 months, see what it does for you. Like when it works well, women are like, oh, there it is. It's not painful anymore. My orgasms feel better.
This question says, my daughter had blood clots due to birth control. Is it true that she can never do HRT? That's what she's been told.
Right. So birth control is a much higher dose, and birth control is a much higher clot risk than hormone replacement therapy. Just good to know for people, right? Because they think, oh, hormone replacement therapy is so unsafe. No, it's actually much safer than birth control, which we give to tons of people.
Yeah.
But if you've had a hormonally mediated blood clot, that is a contraindication to estrogen. Not a contraindication to progesterone and testosterone, because the data says those two hormones don't increase your clotting risk. But if you're going to find a provider to give you estrogen, transdermal, because the data says transdermal doesn't increase your clotting risk like oral does.
Okay.
And the reason for that is oral goes through your liver.
Okay.
And the liver is where you make your clotting factors.
I see.
But you're still going to be hard pressed to get somebody to trust estrogen on you if you've had an estrogen-mediated blood clot.
Okay. Is there currently a sublingual form of testosterone or a pill form of testosterone for women? So
sublingual would be compounded.
Okay.
They're commonly called troches.
Okay.
It's a funny word.
Yeah. Weird.
Yeah, it's weird. But some people prefer that. Again, I tend to use the cream because it's easy to put it on when you're doing all your other creams. Creams or gels. There is an oral testosterone dose that's out now that's a dose for men, but there are going to be coming out with a lower dose. They're not going to get it FDA approved for women at this time.
Why? How do you know that already?
Because I know people.
Oh, you know the industry.
Yeah. So right now it doesn't. Right now we're probably a couple of years away from an FDA approved female product, just because of the FDA and regulation.
Yeah.
But in my lifetime, it's going to come. So oral will be coming for people who like oral. It's just not, the oral that's available is not appropriately dosed.
Okay.
There is an old oral medication that's methyl testosterone, and I think it's ethinyl estradiol. Old med, it's around, it's cheap, it's a prescription. That's a synthetic form of testosterone. It's a synthetic form of estrogen. It's not everybody's favorite medication to use. Certainly, I think there's more bioidentical, safer ones to use.
Okay.
But it's out there, it's available, and people are going to hear about it.
What about that woman who is, let's just say she's menopausal and feels great on testosterone. She wants to put on muscle. She wants to get her body fat down. She wants to look like a fitness competitor. What do her ranges look like? And is there a point at which you can say, okay, these side effects now are irreversible?
Yeah. So some women do better and feel better at slightly higher doses. And what do I mean slightly higher? I mean lower 100s. Certainly when you're getting into 200, 250, you are going to start seeing those androgenic side effects. Voice changes, which are not always reversible, hair loss, that male pattern balding, enlargement of your clitoris. So to me, it's, certainly would be outside of the traditional standardized medical practice to push a woman higher unless that's what she wanted to do. Remember, we let women take 10 times the dose of testosterone. There are people who want to live as men.
Yeah, of course. Yeah.
Their choice, their body, and they do wonderfully well.
Yeah.
But the higher you push, the more side effects you are going to get.
Yeah.
But again, for her, are you prioritizing your protein?
Right.
You have to eat to get muscle.
Fantastic. There's so many people watching right now, so many women who are like, I can't have this conversation with my doctor. How do I find a doctor? How do I advocate for myself? What advice do you have for them?
Yeah. So I think we're just at the very beginning, coming out of that 20-year scare from the Women's Health Initiative, that estrogen's safe. And people do better, they're healthier when they take these hormones. I'm not advocating that everybody needs to get on hormones. This is an individualized decision. But we're just starting to have this conversation. And I think testosterone is the new kid on the block as far as this goes. So you can't just go into your doctor and they're not going to advocate for you and your hormones. It really is coming from the women. The best way that I've found is for a woman to go in is to say, I would like to try this. I will come back in 3 months and I will tell you how I do. That follow-up's incredibly important. Doctors love to know that you're doing okay, that something's working well, and really to be in partnership with you to see if we can make your life better.
That's fantastic advice. Where do you suggest people who want to, can people work with you? Can they reach out to you, or do they have to live in your state?
So currently I only practice in Washington State. And so you have to come to see me or do telemedicine in Washington State.
All right. Yep. So how can they reach you? KellyCaspersonMD.com.
Okay. Or I hang out on Instagram just like you.
And you have a fantastic podcast.
Yes.
Same title as your book.
You Are Not Broken.
You Are Not Broken. We will link to it below in our show notes. Your book is fantastic. Where can people get that? On your website or?
The website will link you to Amazon.
Okay, great. Highly recommend it. She's funny. Like you make very clinical, sometimes taboo topics. Very interesting, a fun read. Like you literally you have to keep drinking it in because you're like, why has no one told me this?
I didn't get taught it either.
As a doctor,
No.
That's so crazy.
I was like 7 years out of practice before I was like, oh, I have more testosterone in my body than estrogen. Oh, especially all the sexual health stuff.
Yes.
Oh, nobody taught us this in medical school. So if you go to your doctor and they're uncomfortable with talking to you about sex or talking to you about hormones, it's because they didn't learn.
Yeah.
But the more women that go in, that's how we're going to change medicine, because the women are demanding these things. It's not going to come from the top down.
And thank you for what you do, because, I mean, it's one of the reasons why you're on the show for a fifth time, because my audience is primarily female, and we need to know these things. And so thank you for the work that you do. It's making a huge difference. I can't tell you how many women are like, because of Kelly, or because I heard this episode, I knew to advocate for myself. I knew what questions to ask. I felt a little bit more prepared and more confident than last time I saw my doctor. So thank you for what you do.
Thank you. It's the best job in the world.
That's awesome. Thanks so much for joining me in this episode of The Chalene Show. Do me a favor, if you enjoyed this, make sure you're subscribed. I checked recently, and we have 70% of the audience who's watching and not subscribed, which is crazy to me. So if you want good parking lot karma, like you're going to get a spot up front when you subscribe to the show, make sure you do that. And don't forget to leave me a comment as well. All right, I'll see you in the next episode.